Assalamualaikum. Is everyone here? Can you guys listen to my voice? Or is it?
Yes, doctor, we can hear you.
Alright, thank you. Okay, so everyone here, can I start the class now?
I think we can start the class now.
Okay, Assalamualaikum and good evening everyone. I'm Dr. Intan. So today I'm going to give a lecture about abdominal radiology. So it's just a brief lecture, just a sort of like introduction to what you will be seeing in radiology department daily. Okay. Okay, so first, what are the modalities in abdominal radiology? So of course we have plain radiograph, ultrasound, CT, MRI, fluoroscopy, and angiography, and last but not least is nuclear medicine or scintigraphy. We have PET scan or PET CT scan. But what I want to highlight today is just these four modalities, which is plain radiograph, ultrasound, CT, and MRI, in which the other two modalities I believe it will be covered by other lecturers for fluoroscopy and angiography and also nuclear medicine. Okay, so first abdominal plain radiograph. So first you must know what is the indication that when you want to request or you want to do plain abdominal radiograph. First, it is a preliminary evaluation of bowel gas in emergency setting. For example, when you want to rule out intestinal obstruction, you want to look for dilated bowel, or you want to look for evidence of pneumoperitoneum. Second, when you want to evaluate of radio-opaque tubes and lines. For example, this is commonly done in pediatric patients in which when they insert UAC and UVC, so they want to look at where is the tip of the lines. But usually in peds, they will do combination of chest X-ray and abdominal radiograph, or sometimes they call as pelvigram, because the tip of the UAC usually lie the common optimal position is at the T10 level. Okay. Okay. Next, when they want to evaluate for radio-opaque pathology such as stone or foreign bodies, to evaluate for post-procedural intraperitoneal or retroperitoneal gas, as I mentioned earlier, and to monitor the amount of bowel gas in post of INS. Okay. And contraindication is the same with any other imaging that involve radiation, which is pregnancy. Okay, so for abdominal radiograph, standard projection is 80 supine. And if you want to look for evidence, pneumoperitoneum or sometimes air fluid level in intestinal obstruction, you might want to do erect position. And KUV is another, it's part of abdominal radiograph, but it is actually more specifically to the KUV system, kidney urinary bladder, in which they want to look at, usually they want to look for stone. Okay, the difference is actually KUV, it will be more more collimated. The skin will be collimated, and it will further involve the pelvic region, because they want to look for pelvic bladder calculus. And additional projection is lateral decubitus, which is an alternative for PAE, right, for evaluation of regas. So sometimes patient is quite ill, cannot erect, so sometimes they can do sitting, but more ill patient that they can't even sit lie in seat position, so we may do lateral decubitus because the air will float out. So that's why you can see the extra luminal air very clear. Okay, so first when you got abdominal radiograph, you look at the bowel gas pattern. This is gas is actually very good as it can provide natural contrast. So when it appears within the bowel, it can give you a natural contrast to compare with the surrounding tissue. But if the bowel does not contain gas, but it contains of fluid, so it's quite difficult to distinguish with the surroundings. So sometimes it's quite difficult to say that bowel is dilated or not when the bowel is fluid in content. Okay, so for bowel gas, we look at the stomach, small bowel and large bowel. So stomach, of course, the normal location is underneath of the left hemidiaphragm, and please do not mistake it as a rim gas of pneumoperitoneum. It's not pneumoperitoneum, it's actually a stomach gas. Okay, next is small bowel. So the normal diameter is usually less than 3 cm wide, and location is typically central location, and you can see there is presence of mucosal fold, or we call it as valvular conniventis. It traverses the bowel lumen from upper to lower part, in differentiating with haustration, because in large bowel, haustral fold, they actually do not go all the way across the lumen. Okay? And for large bowel, it can be up to 6 cm, but cecum and sigmoid can be up to 9 cm in diameter, and the location will be peripheral. And I said you need to differentiate between haustra and also valvular conniventis. And sometimes, or most of the time, you can see there's presence of motile appearance, which is actually feces. Okay, there's no feces in small bowel, but there is feces in large bowel. Okay, so these are the general rule in bowel gas pattern, 3-6-9 rule. Okay, in general, small bowel should be less than 3 cm, large bowel should be less than 6 cm, and apart from cecum and sigmoid, which it should be less than 9 cm. If the bowel diameter measures greater than this, so you must suspect obstruction or paralytic ileus. Usually, paralytic ileus, it occurs, you can see there is sort of like generalized dilatation of the bowel. In compared with obstruction, usually there is sort of like focal dilatation. Sometimes it usually only involve the small bowel, or only involve the large bowel. Small bowel is just like probably just appear prominent and all, because there is sort of like mechanical obstruction. But in paralytic ileus, usually it occurs because of sepsis, sometimes because of peritonitis. So the condition appears more generalized. Okay, so this is the abdominal radiograph that you see, but this is how you should visualize the abdominal radiograph. Okay, can you see my pointer here? Yes, okay, alright. So, okay, thank you. So this is the liver shadow. Okay, as you see, actually it just does not really extend beyond the 12 ribs. Okay, just there. But you see the shadow sort of like elongated until the right iliac fossa, sort of like that. So actually it indicates hepatomegaly. Okay, so this is the inner shadow, orange one. Okay, normal location is at the level of T12 to L1, sometimes L1 to L3. Okay, and really the size is about 3 vertebral body size, like this one. Okay, so if you see the shadow is, for example, it takes about 4 vertebral body height, so you must suspect that probably this kidney is enlarged, or probably there's a renal mass or hydronephrosis. Okay, so this is kidney, and then you can see this is the ureter. See, this is the ureteric course. So the ureteric course is actually lateral to the transverse process. Okay, this is transverse process. Okay, you just imagine, and then it courses along the lateral side of the transverse process, and then enter the pelvic cavity. It runs medial to the SIJ. This is the sacroiliac joint. Runs medial to the SIJ and then goes into the pelvic cavity. This is the bladder. Okay, so when you request for KUB, you want to look for stone. This is the area of opacity or calculus that you want to look at. You look at the renal bag over here. You look at the ureteric course along the transverse process, the lateral part of transverse process, slightly medial to the SIJ, and then you look at the pelvic cavity within the bladder. Okay, so kalau tak ada lah. Bukan tak ada lah, maksudnya there's no radio-opaque calculus. Okay, as you know, actually not all the renal calculus are radio-opaque. It's only about 75% of the calculus will appear radio-opaque on thin radiograph, because another 25% can be provide and all. It might not appear as opaque. Okay, but if you do ultrasound or CT scan, you might see the calculus. Okay, so no radio-opaque calculus doesn't mean that there's no calculus. Right. So, okay, after finish seeing the kidney, renal shadow, ureteric course, and the bladder, and then you look at this is psoas shadow, the red one. Okay, you can see the margin really well. Okay, but if you can't see the margin, sort of like obliterates, and with the right clinical indication, for example, they want to look for psoas abscess, so it might indicate that there might be some collection over here, or it can be ascites because presence of fluid. That's why you can't see the psoas margin. Okay, and this is actually the skin. Okay, so for bowel gas distribution, okay, so for bowel gas distribution, so the red color, the red one is actually, this is the large bowel. Okay, you can see this is cecum, this is ascending colon, hepatic fracture. This is transverse colon, splenic fracture, descending colon, sigmoid, and rectum. Okay, but on plain radiograph, you might just see this sort of like motor appearance. It's actually feces. Okay, these are all feces in a large bowel. Okay, and this is small bowel. The blue one is the small bowel. If it's not dilated, actually it's quite common for you not to see the shadow actually. Okay, this is the small bowel, centrally located, and sometimes you can see presence of valvular conniventes, like this one. Okay, this is the large bowel. You can see there's some motor appearance indicating feces. Okay, so next, ultrasound. This is quite commonly done. has many advantages. One of the most advantage is it doesn't involve radiation. It's more readily available than advanced cross-sectional modalities. And I think nowadays most of the clinic in GP or KK, they already got their own ultrasound machine. And it's less expensive. It's real-time and useful for evaluation of physiology as well as anatomy. Real times mean that is that whatever changes that occur, you can see there and then, okay? And you can also evaluate doctor, and there's no adverse effect of metallic object in contrast to CT and MRI. MRI, of course, is sort of like contraindication, but for CT it's not contraindication, but it can give artifact. And it can easily be extended to include other organs or contralaterally. So, for example, you can combine, you want to do ultrasound on the thyroid, or suddenly you want to add on left lower limb, so it doesn't matter, okay? But the advantages, of course, it's operator dependence, requiring high degree of training, and you need a lot of experience, and even some people might see a different thing. That's why not all the people can perform ultrasound. Okay, and ultrasound not capable of evaluating internal structure of tissue types with high acoustic impedance. For example, bone or air. So when we see plain radiograph, for example, they give us a plain radiograph with dilated bowel. So they ask, we want to rule out intra-abdominal collection. So we know actually this is ultrasound is not good in this patient because there's already a lot of bowel gas that will impede whatever the finding. If there's presence of collection, we cannot see very clear. So that kind of patient, we might suggest just proceed with CT scan. And of course, it also has its own set of unique artifacts that can potentially degrade the image quality or lead to misinterpretation. And some ultrasound exams may be limited by abdominal large body habitus because if the patient is quite big or very big, the sound wave cannot really penetrate the body tissue. So the image is not quite clear. But of course, if this patient has large body habitus, it also has very limited choice of imaging. For example, CT scan, there are certain limits to patient weight. And also, furthermore, MRI, you can see the gantry is very small, so only a very limited weight of patient can go inside. Okay, so for general indication, ultrasound is good for solid organ assessment, liver, spleen, kidney. You want to look for collection, mass, or calcification, and also good for assessment in aorta. For example, they want to rule out intra-abdominal aortic aneurysm, you can see, and also good to assess for renal stone or gallstones. But when not to use ultrasound, as I mentioned, when want to assess a bowel lobes. For example, if you want to look for intestinal obstruction, so this is not a good choice. If you want to assess for bony structure, this is also not a good choice. And if you want to assess for retroperitoneal assessment, for example, they want to look for retroperitoneal collection and all. Actually, we can do, but with certain limitations. Perhaps patient needs to be in prone position, etc. Okay, so this is an example of kidney. Okay, this is kidney, the normal kidney, and this is the hydronephrosis. Okay, you can see this is actually the central ecocomplex of renal sinus. It comprises of mainly fat, so it appears hyper on ultrasound. But if there's obstruction, the ecocomplex will be dilated the pelvic cavitation system will be dilated. So as you know, fluid will appear hypoequic in ultrasound. So it will be appear like this. Okay. Okay. This is gallbladder. Normal appearance of gallbladder appears as well defined and quick. Okay. In ultrasound, how you describe is actually echo because it involves echo. If there's completely black like this, we call it as anechoic. If it's just macam dark but that's macam not very dark, we call it hypo. For example, like this one, this is hypoequic. Okay, if it's bright, we call it as hyperequic, like this. Okay, so gallbladder appears as an anechoic, elongated structure, well defined, like this one. But this is abnormal because you can see there's presence of multiple echogenic lesions or structures within that projects posterior shadowing, which means that there's presence of gallstones. Okay. Calculus in ultrasound, it will show posterior shadowing because when you give ultrasound wave, okay, this is the anterior part, you give the ultrasound wave, and then this dense bones or calculus, it will sort of like absorb, does not penetrate, does not allow the sound wave to penetrate behind. So that's why it will give the posterior shadowing appearance. Okay, so this is how liver abscess appear on ultrasound. Appears as hypoequic and it has irregular margin like this. Okay, as compared with, for example, like cystic lesion, it will appear anechoic with well-defined margin. Okay, this is just to show you how we should see ultrasound, renal in ultrasound, in longitudinal, like this one, and also in axial view. Okay. And this is, anyone knows what is this? What organ is it? Siapa tahu? Siapa? Equine. Anyone knows? What organ is it?
Kidney.
Kidney macam tadi. Kidney macam ni. Ini tips, hint, it located centrally.
Is it pancreas?
Yes. Siapa jawab tu? Fatin.
I just read Ibrahim answer.
Oh, okay. So I tak boleh baca chat. Yes, this is pancreas. This is the pancreatic head, body and tail. Alright. Any questions so far? Tak ada Okay, so next is CT. Okay, so general indication. In abdominal pain, abdominal sepsis, to look for collection, bowel inflammation, solid organ abscess, bowel obstruction. Bowel obstruction actually mainly when they want to look at what is the cause of obstruction. For example, they want to look whether there's presence of tumor or there's presence of transitional zone, transitional zone you usually see in addition, patient with addition, for example, in previous history of surgery. And to look for post-operative complications such as any anastomotic leak, and in trauma, of course, because you want to grade the trauma injury, for example, liver laceration, spleen laceration, renal injury. And of course, in vascular compromise such as aortic aneurysm, aortic dissection, and mesenteric ischemia. Okay, so what is the benefit of CT? It is quick and accessible. It is reproducible finding. Okay, unlike ultrasound, the image might not be reproducible. It means that if different person do it in different angle, the appearance might be similar, but for example, the measurement might be slightly different. But if you do CT scan, if you repeat it, anyone repeat it, so you can get the same reproducible finding. And then it can provide complete assessment of abdomen and pelvis. But limitation is, of course, involve ionizing radiation. If you do abdominal radiograph, abdominal CT is about 100 times the dose of chest radiograph. So it's a lot of radiograph. That's why you need to think clearly when you want to request for CT abdomen, and that's why radiologists are very fussy when it comes to approving or accepting the request, because we need to think whether this patient is going to benefit a lot from the CT or not, or it just give an extra radiation to the patient. When you give radiation to patient, you might not see the effect now, but patient might get the effect 10 or 15 years later. Okay, as you know, radiation can lead or can increase risk for cancer. And of course, it often requires iodinated LV contrast. So there's a risk of renal impairment and also risk of anaphylactic reaction. That's actually one case when I was very early in radiology department. Patient came for CT, walking, elective, already covered for allergy, already given prednisolone. But after we give contrast and we do a CT scan, suddenly patient collapsed. We send patient to ED, and then, however, patient succumb because of anaphylactic reaction. So, that's why primary team might think, radiology is very fussy. There's no ada allergic history escape, but China for semua, everything must be covered. Of course, because we see this kind of patient walking very well, but end up die just because of allergic reaction. Okay, so patient preparation. You need to discuss whether CT is the best modality for diagnosis in question. Check history of allergy, especially to medication and seafood. Any history of hypersensitivity, such as asthma or rhinosinusitis. So if there is, you need to properly cover with prednisolone. The standard protocol we give is we give it twice, BB lah. 12 hours and 2 hours before. And check for renal function if there's any need for renal protection. I think this is actually depends on the medical team. Some patients they covered with NEC, but some patients they just give hydration. Okay, so for procedure, Again, check renal function, patient lie on CT table, scout image to plain CT, and plain CT if it's necessary. And if we give IV contrast, it can be given either via hand or via power injector. And in some patients, we do delay study. Okay, so this is the example. If you see the CT control panel, you can see this is what we call as scout image. Okay, when they want to scan, they want to determine where is the field of view of the scanning. Alright, this is the image that they will scan. These are the faces that they will scan. For example, this is atrial faces, portal venous faces, and this is delay faces. Okay. So this is actually the window that they will provide us. This is a soft tissue window. Sometimes if you want to add lung window, bone window, so they will recon over here. Okay, so this is a CT gantry. So patient will lie supine over here. Hold on. So sorry, ada datang dulu. Okay. So this is table that where patient with lie supine, head raised, head rest. This is the contrast injector. Okay, so when we scan patient, so the table will go in and start scanning. So there are a lot of protocols that I can't cover all. So basically, standard CT abdomen, we do clean, portal venous and delay phase. This is standard one. If you want to look for gallbladder empyema or intra-abdominal collection or anything like abscess and all, this is just a standard protocol. Okay, for if you want to look for renal calculus, we usually do plain CT KUB, and actually it has been a misnomer. If you see the form, they will write as CT urography. I think this is misnomer. I think the whole Malaysia, I guess, they write as CT urography, but actually what they mean is just a plain CT KUB. Doesn't involve any contrast. Okay, this is CT urography. The real CT urography actually is when you do CT KUB with contrast. Sometimes they want to look for any urethric restriction, or so it's sort of like CTI view. This is CT renal protocol when they want to look for renal mass. They want to characterize the renal mass, or when they want to look for classification of renal cyst. You know, when we see renal cyst on ultrasound, if it's complex, such as when there's presence of septation or calcification, so they will proceed to CT renal protocol, so that we can further classify if patient is in high risk. There's a classification, we call it Bosniak. If it's in high risk, we might want to have a closer follow-up, or even they might want to just nephract the patient to get the HPE. Okay, so this is CT cystography. Usually we do in trauma case when we suspect bladder injury. Okay, in this case, we will infuse the bladder with contrast. Usually we use iodine, about 300 cc, and then we scan to look if there's any contrast leakage. Okay, so for CT liver protocol, when we suspect for hepatoma, or we want to make sure that the liver masses is hepatoma or not, basically. Or it can be metastasis, or it can be abscess. CT pancreatic protocol, where we want to characterize the pancreatic lesion. For adrenal protocol, we want to characterize the adrenal lesion. And CTA of the abdomen, when we suspect aneurysm, or sometimes when we suspect for ischemic bowel, we will do CTA abdomen, because you want to look if there's any thrombus within the vessel, the aorta, the artery, and also the vein. And last but not least is CT colonography. Okay, CT colonography, usually this is not the first line. Usually we will do when patient refuse colonography, refuse colonoscopy, or sometimes incomplete colonoscopy. For example, it's quite sort of difficult colonoscopy. They can't complete the examination, so they will request for CT colonography. Okay, just know this one. Okay, so these are some modern CT application. We can do MPR, we can do maximum and minimum intensity projection, or MIP. We can do VRT. We can do cinematic rendering technique, virtual colonoscopy fly-through, I mentioned earlier. Dual energy CT. Dual energy CT actually has many benefits. We have one. The one that we have here is actually dual energy CT. One of the benefit actually, for example, we can classify what types of the calculus, for example, renal calculus, what are the types, whether it's provide, whether it's calcium oxalate and all. Or it can be used as metal reduction artifact. For example, if patient has implant, so if it can be quite useful for reduction of the artifact. Okay, so this is example of VRT, just a recoil. You just do a normal scanning, and then you just click the button at the software, and it can provide you this kind of image. I rarely look at this. Okay, this is also example of VRT when they want to look at the pelvic erectile system. Also really look at this. This is an example VRT for colonography. This is cinematic rendering technique. Sort of like macam sort of cadaveric image kan. Okay, sometimes it can give you macam beautiful image of any masses that you want to look at. This is a virtual colonoscopy, CT colonography that we do. You need has anyone seen this procedure? Not quite common, but we do it quite I think every week for adalah a few cases. So usually patient need to lie both supine and forward. You need to pump air within the rectum. Pump, and then you try scan, tengok is it adequate or not. If it's adequate, and then you start scanning, because we want the large bowel to be very distended with gas. Okay, but before the procedure, patient need to be prepared by given barium tagging. We call it barium tagging. Okay, this barium tag, actually, it will sort of like tag the residual pieces in the large bowel, so that when we process the image, so we can know that actually this is actually pieces. So for example, we have like this button, and we can say like remove barium tag, so all the pieces can be deleted, so we can see the wall very clear, sort of like that. quite canggih lah kan. This is how we do it. We fly through the large bowel. Okay, from rectum we go through here, side. At the same time, we look at the image on the left side. Okay, to see whether it's correlate or not. And if there's a mass, we can see the mass, and we can also see concurrent mass over here. Okay. Okay, so for MRI, actually it's a much less commonly used in clinical practice. Of course, as you know, MRI provides better soft tissue contrast resolution, and it has greater sensitivity for the presence of IV contrast agent as CT. What it means actually, if you do CT scan, you only use one type of contrast, which is ID. So ID will enhance any sort of organ, sort of like that. Okay, but in MRI, we have specific contrast agent for specific organ. For example, in MRI liver, we want to look for hepatoma. For example, okay, usually if patient has liver masses, we want to characterize what is the mass, we will do CT liver protocol. But if it is inconclusive, we can proceed with MRI liver. What is the benefit of MRI liver? We will use a specific contrast agent for liver masses that only certain lesion will uptake the contrast, sort of like that. So it's quite specific. Only hepatoma will produce this kind of image. Unlike not the metastasis, not the regenerative nodules. So it's more specific than CT liver protocol. But of course, kenapa tak semua kita buat MRI liver? Of course, because it takes a longer time and it is more costly. Patient will need to pay to buy the contrast themselves, which is the contrast itself. Price is about 1,000. Only contrast, not the MRI. Okay, so that's why it is not all of the patient will proceed with MRI liver, only for certain cases. Okay, next is biliary and pancreatic duct assessment, MRCP. Sort of like ERCP, in which you do a GDS and you scope patient to look at the biliary tree. But for MRCP, you don't have to scope patient, but they will highlight the biliary tree for you. Okay, but of course, MRCP, the disadvantage, I think the resolution is not so good. You still need some clues, some clinical assessment before we do MRCP. Okay. Next is urinary tract. We can do MR urography, pelvis and pelvic floor for rectal CA, for local staging. Okay, you know that this is a common, this is standard imaging protocol. When you see rectal CA, okay, for example in CT TAP or from colonoscopy, so they will request for MRI rectum. This is for local staging. So from local staging, they will determine whether what is the next management, whether they want to operate first or they want to give chemo first. Okay. And next is placenta evaluation for abnormal placenta adherence. This is for example, patient has previous history of seizure, and you see the placenta is low lying, so they want to determine whether there is presence of placenta accreta or percreta. And last but not least is assessment of large and medium sized vessel to look for renal stenosis with MRE of the kidneys. Okay. But this is not so common that we did. Okay. And limitation, of course, it's significantly longer acquisition time. It's more predisposed to artifacts, especially motion artifacts from the breathing or bowel movement. It is less available and more expensive and technically more challenging to perform and interpret. Right. This is an example of MRA of the renal. Okay. See, there's presence of stenosis at the right renal artery. Okay, I think that's all. Just an overview for abdominal imaging. Anyone has any question? Ada yang tak faham?